In this video, we continue Chapter 6 with Anatomy and Physiology, and we're going to focus on the anatomy and physiology specifically of the respiratory system. So the respiratory system is everything involved with inhalation and exhalation, oxygen on the way in during inhalation, and then carbon dioxide removed from the blood during exhalation. Now, the carbon dioxide interacts with the fluid in the blood to actually produce something called carbonic acid. And so respiration will help balance the body's internal pH. We can divide the respiratory system into upper and lower airways, and the dividing point will be the epiglottis. The epiglottis is that valve that closes over the top of the trachea while you're eating to make sure that food and liquid goes down the esophagus instead. Now beware that the epiglottis may not close if a person is unresponsive, and in that case, if that person vomits, we've got some potential for significant damage when the vomit enters the trachea and potentially the lungs. The upper airway is essentially the part that we can make interventions with. We're able to access, using airway adjuncts, everything through the nose and the mouth back to the pharynx, the chamber behind the nose and the mouth at the throat, down to about the vocal cords. The epiglottis, again, is the dividing point between upper and lower airway. During inspiration, air will enter through either the nose or the mouth, and in that process, it's going to be humidified and warmed. Now, large particles will be filtered by hairs within the nose. Anytime you get a booger, it's essentially things that have been trapped there. And whether air enters nose or mouth, then it will pass through those other structures, the pharynx, and into the lower airway. So the lower airway consists of the trachea, the bronchi, and the lungs, which branch into smaller passageways, the bronchioles and the alveoli. The trachea can be felt in the anterior part of the neck, and it's containing rings of cartilage that give it some structure so that it doesn't close off. And then where it branches at the bottom of the trachea, we have the bronchi moving to both the left lung and the right lung. Bronchioles, smaller branches, think of the branches of a tree, and they can constrict. They have muscular walls, and so sometimes in an asthmatic, this is actually what is occurring, and that's restricting their airflow. Cold air or chemical irritants can cause that restriction as well. The alveoli are the terminal structures. They have a very, very high surface area, and they're adjacent to the capillaries. Again, small structures with a high surface area in the cardiovascular system. And where we have those two structures in contact and the high surface area, we allow for oxygen to pass in one direction and carbon dioxide to pass in the other direction. We get that gas exchange. Now, to allow this to occur, we have the mechanical process of breathing. And essentially, that's principally done by the diaphragm, which sits at the intersection of the thoracic cavity and the abdominal cavity. And that large, flat muscle, the diaphragm, is essentially arch-shaped. So when it contracts, it shortens the arch. It becomes flat. And what that does is expand the lungs. The lower pressure inside the lungs and the higher pressure outside atmospherically is what brings air into the lungs. Relaxation of the diaphragm, which is passive, allows for exhalation. Sometimes you need to assist the diaphragm with accessory muscles, the muscles between the ribs, and so you can further expand your rib cage by activating those accessory muscles and providing support for inhalation. Now, the diaphragm is controlled automatically from nerves in the spinal cord, and those are going to be between C3 and C5, very much near the top of the neck. Now, one way we can measure the effect of respiration is with minute volume. Minute volume is simply how much air you inhaled during one breath times the number of breaths per minute. So if you think about it, if I inhale 1 liter and I do that 20 times a minute, I'm inhaling 20 liters per minute. You can increase minute volume 2 ways: greater volume, meaning a deeper breath, or a higher rate. Now, the trigger for breathing is actually the level of carbon dioxide in the blood, because carbon dioxide, when it encounters the fluid in the blood, reacts to form carbonic acid, and so the pH of the blood actually changes if the CO2 level gets too high, meaning the acid concentration goes up, which really means the pH goes down, it gets more acidic, the respiration rate increases automatically. If someone has a chronic obstructive pulmonary disease, such as emphysema, their drive to breathe is not based on carbon dioxide levels. Now, physiologically, we have to be aware of resistance to airflow. And so the causes for that and things we need to be mindful of as patrollers is in the upper airway, some injury that can physically block passageways and the flow of air, or in the lower airway, inflammation due to contact with a chemical irritant, cold air, asthma, or even infection. That increased resistance means less oxygen is entering, and the exchange of oxygen and CO2 is going to be minimized. The body's response is going to be to breathe faster. The rate will go up. So that's a clue when you encounter a patient with an injury or an illness. In summary, the respiratory system is divided into upper and lower airways. The upper airway is where we can intervene. Breathing is controlled by the level of CO2, with the exception of COPD patients, and an increase in rate to maintain that effective oxygen exchange is our body's response to some resistance of airflow.